So I'm just going to jump right into this. Two big issues that people are concerned with today. One's the election. We're not going to talk about that. And the other is the COVID virus. And Dan has been on a number of radio talk shows, and I've tuned in every time I've been able to, and find it fascinating. And that's what gave me the idea to see if he would do a couple Wednesday nights with us. If you don't know Dr. Dan Rudd, he's an internist. He has offices in Smyrna and Murfreesboro. He's also a physician to the inmates in the Rutherford County Jail. That's an interesting thing in itself, for sure. He's a father, he's a grandfather, he's a member of Woodmont Christian Church. He's a great friend of mine. He's just a really good guy overall. And he lives to help other people. And something he doesn't talk about, most people don't know, but he, on his own, opened up a women's shelter, a shelter for women and children in Murfreesboro, which he keeps going down there, just shows his spirit. But he's also the smartest person I know about the COVID vaccine. I've been talking to him. He's been keeping me going ever since March. And I thought our format tonight would be, I'd let Dan maybe open up with some comments about the vaccine or where we are today. And then you all can respond by asking any questions or concerns that you have about the vaccine. So Dan, I'll turn it over to you and let you go.
Thanks, Roy. Well, first of all, let me preface this with, I'm not an infectious disease expert, but I take care of a lot of COVID patients, and I stay pretty much abreast with what's out there. There's such a tremendous amount of information coming out now, almost daily, that it's really impossible to read everything, but I read a lot. And I'm just going to kind of summarize a little bit about the pandemic, about the virus, then kind of talk about treatments that are available, treatments that are on the way, and where we are right now with the vaccine, and where we are going into the winter. And if any time somebody has a question, just stop me any point. This is very informal. Just, I feel like I talk about it a lot, so it kind of comes out a little fast sometimes. And if there's something I say that's a medical term and it's not clear, just stop me. Let's see. The COVID-19 is a disease that's caused by the SARS-CoV-2 virus. It is a coronavirus that is a family of viruses that we've seen before. It is the same family that includes 4 common cold viruses, and also the 2003 MERS virus, which was really SARS-1. The experience we had with that was very limited with MERS, which was the Middle Eastern Respiratory Distress Syndrome virus, but it seemed to have a fairly high mortality, but the case number was very low. It just didn't spread very much, and thank goodness it didn't, but the early fears were that we would have a pandemic with that. We didn't. And there were about under 700 cases, I think, of MERS or SARS-1, and it just sort of disappeared. The host for that, the intermediate host, was a camel. Then we had basically a few years that a case would pop up every now and then. The virus is not gone. But then this last year, in late 2019, SARS-CoV-2 popped up and spread from China. This virus it's what's called an RNA virus. RNA is a type of nucleic acid. There's DNA and RNA, and viruses can have either one, RNA or DNA. And they can be double-stranded or they can be single-stranded. It's kind of more complex than I want to make it for this discussion, but it's important in that RNA viruses are generally easier to tackle. Now, this one has a lot of information in it. The RNA strand is very long, and so it basically has a lot of stored information in the nucleic acid. The virus has a structure that is basically a lipoprotein envelope with protein spikes that stick out from the envelope. Typically, there's 26 or so spikes on a virus, but that can vary some. And that spike is made of protein. And that protein is what attaches to the human cell to basically allow infection. The spike is also the protein that is identified by our immune system when we fight it. So that gets to the antibody test that we use is basically a spike protein antibody that we try to identify in the blood when somebody says, do you have antibodies? The virus is very contagious. One of the things that we do know is as far as viruses go, the most contagious virus that we know is probably measles. And measles has basically from one primary person, typically the spread of it is to about 20 different people, which they call it an R value. And on COVID-19, the SARS-CoV-2 virus has an R value of about 1.2 to 1.4, which sounds tricky, but it's enough to spread it a lot. And so basically we get into a situation where, you have components of whether or not the virus is dangerous. One is, does it spread easily? And the second is, when it spreads and infects somebody, does it cause a bad disease? Now, we're learning a lot about it. And so our experience with it is changing. And what we saw initially was that, there were death rates as high as in the 30% range in Italy last winter. Now that death rate is dramatically lower. And so one of the things that doctors do is as they describe death rate, they have a lot of different terms that are used. One is called case fatality rate, and one is called infection fatality rate. And they sound the same, but they're not. They're very different. And basically, the case fatality rate is based on a case that's diagnosed as positive for the virus. And you see how many of those people actually die. The infection fatality rate is really more helpful. What that looks at is the number of people that are infected. Now, many of those may not develop an actual case of COVID-19. They stay asymptomatic. So they can have, the infection, but never show any sign of disease. So they don't rise to the level of being a case. But that's really determined almost statistically because it's hard to know exactly how many people have an infection when they have no symptoms because you can't say, are you infected? And have them answer you. They don't know. And so the infection fatality rate is actually very low. Thank goodness. Thank goodness. But it's interesting because most viral infectious diseases affect children much more than they do adults and older people. Children are, they die from lots of infectious diseases in the world at higher rates than adults. This one is the opposite. Children almost never die. And as you get older, you're more inclined to be sick and die. But one of the things that we're seeing now is that the infection fatality rate is under 1%, and really, it doesn't really go up much until you get over 60. When you get over 60, it gets up to 5 or 6%. You know, and that's variable. I mean, that's hard to really know because a lot of people have comorbidities. And when you're talking about people with no comorbidity, that in other words, they're not overweight, they don't have diabetes, they don't have heart disease. If a healthy person, then the likelihood of getting sick is probably about 5%, and the likelihood of dying is probably about 1.5 or 2%.
Can you compare that, say, maybe to the mortality rate with the flu, for example, to give them a comparison, or some other diseases?
Yeah, the flu is much less fatal. It's probably 10 times less fatal than COVID-19. You know, so that, and flu is actually, the age distribution is different because babies and children die from flu a lot more than they do from COVID-19. They're more susceptible. But a lot of people think that flu is just as dangerous or maybe more dangerous, but it's really not. And one of the nice things is the things we do to mitigate against infection, like masks and distancing, also helps to decrease the risk of flu. So all the things that we're doing for COVID-19 also help with all respiratory viruses, which includes flu. And as we, you know, learn more and more about this, even without really specific medicines for most people, we're seeing better outcomes. And I think that, you know, one of the things that's really important, and I want to kind of go through the phases of the disease. You know, one of the first things that happens is you have to get inoculated with the virus. You have to come in contact with it, and the virus has to attach to your epithelium, to the lining of your nose, pharynx, and as far down as it goes. That attachment is something that, you know, at that point, our body starts to kick in. Now, one of the things that I think is important, and I really learned this back from years working with people with allergies and other respiratory viruses, is basic nasal lavage. And I think that for people, especially people who are at increased risk, a neti pot or a nasal lavage kit is very important to do a couple of times a day, morning and night. Because if you can dislodge that virus before it enters the epithelium, you've basically averted the whole thing. And it's just like, you know, we talk about washing our hands. Well, washing your nasal passages is just as important. You're not going to read that too much, and that's one of my personal beliefs, but there are articles to support that. The next thing is, once the virus gets in the epithelial cell, our immune system starts to work very fast. And one of the things we've learned is immune function is affected a lot by vitamin D levels. And the Europeans have done a lot of work.
Yeah. Do you think it's good?
Enjoy.
Good.
But vitamin D levels are important in two things. One is it's important in the early immune response, identifying the antigens and beginning the process of attacking it. And it's also important in the later part where you control the acceleration of the immune response to limit the chance of going into what's called the cytokine storm. And really in the European study, it was what's called a retrospective study, which means it was looking at information after the end, after people had gotten through, either gotten well or died, and you analyze everything. That's not the best way to do a study. The best way is what's called prospective, where you plan the study and you do it ahead of time. But they were able to show that people who had normal levels of vitamin D or who were supplemented with vitamin D had a 50% less chance of ending up in the ICU. And I think that's pretty dramatic. So that's another thing that I think is easy to do. You know, it's like all you have to do is but vitamin D is a fat soluble vitamin. And so in order to not overdose on vitamin D, taking it has to be directed by a blood test. You can't just go take vitamin D and just think, oh, well, if one pill's good, 5 are better. That's not the way it works. You can get toxicity from it, and it can damage your liver. And so vitamin D has to be basically done by using blood levels. But again, let's go back to what vitamin D did, and that's immune modulation. That's in the early phase of the infection. Vitamin D is important. Probably zinc and vitamin C are also important there, but we don't know as much about what they do exactly. But basically, as the virus enters the cell, the virus injects the information in from the RNA, and it takes over the manufacturing process of the virus, of the cell. And so at that point, you're in the active viral replication phase. And during that time is when you want to use direct antivirals. Now, we have like Tamiflu for influenza, and we have remdesivir, which was really designed for HIV, but it's being sort of retooled and used for this, and it's helpful, but it's not the silver bullet that we're looking for. This is the stage that hydroxychloroquine was thought to be effective, and then there's another drug that is ivermectin, which is also used for scabies, that is thought to be helpful, but the doses might be so high that we couldn't take it. Right now, we don't really know. There's not a lot of financial incentive for drug companies to drugs that are cheap and are available. And the advantages to them are to develop new drugs that are expensive. And so, drugs, I hate to call vitamin D a drug, but treatments, therapeutics like vitamin D, C, zinc, hydroxychloroquine, ivermectin, those are cheap. And they're not going to get a lot of play and study, but without those things, it's hard to recommend specifics for treatment. Now, we know basically vitamin D is something we all need anyway, so that's an easy one. But the others are kind of up in the air. Yeah.
While we're talking about treatment, we're in the early stages. Dan shared with me back in March, he said, if you'd use the nasal wash, it's every day, and keep the COVID from being able to attach themselves to your lining in your sinuses and whatever, it would be very helpful in preventing it. And I've been doing that every day since. Dan, you want to say anything more about that while we're in these early stages?
I believe that's a very easy, cheap thing. Has no side effects. It's a little messy, but I mean, it's free. It's just water with a little. They sell prepared stuff that you can add, or you can do like a half a teaspoon of salt, a quarter of a teaspoon of baking soda mixed in with a cup of water, and use it kind of at a lukewarm temperature, and use that every day, and it just helps to clean all that out. It's hard to do exact studies with it, but it's interesting because, they did do an animal study where I don't know how they hooked the rats up to it, but they did. And what they did is they had a cage of rats. They did that too. A cage of rats. They didn't do that too. And then they aerosolized a virus that was similar to SARS-CoV-2 and that they could track infection in. And the rats that had the nasal lavage, none of them ever got sick. The cage that had the rats they didn't do that to, all of them got sick. And so, that's an easy, cheap thing. It's just one of those things, you have to just intentionally do if you want to do it. And then, let's going back to the direct antivirals, there is, the downside also of remdesivir is that it's given intravenously. And so it's hard to give early in the course of treatment because you basically have to have an IV. And that's difficult. Now they're developing, and it's in study right now, a form of remdesivir that is oral that you can take as a tablet. And that's going to be out before too long, but I'm sure it'll be expensive. And so, as they're studying a lot of other antivirals that are in the same vein as this. But when you look at the disease course, it's really interesting because the disease has different phases, like we were talking about. This viral phase sort of transitions into the immunologic phase. The immunologic phase is really the bad boy in the whole picture. That's where, our body develops a reaction to this. And then for some reason, that reaction gets out of control. And it accelerates, and that's been termed the cytokine storm. And then there's, and let's talk about that just a minute, but, that typically starts at about day 10, after the, day 0 being the day you get infected. Day 0, and then the incubation period is usually averages 5 days. And then the disease is over at the viral disease is over at about 10 days. And then it goes into the immunologic phase. That's why the CDC has changed the restrictions from a testing-based restriction to a symptom-based restriction as far as returning to work, school, that sort of thing. And what they basically say is they count day 0 as the day you have a positive PCR test. And a PCR test is the nasal swab test. And then at day 10, if you're not on any fever-reducing medicine, you have no fever, and your symptoms aren't bad. They don't have to be all gone. But if they're mild to moderate symptoms and you feel okay, you can go back to work. They've done a lot of studies looking at the time course of the disease, and basically the infection itself has played its course in 10 days from that first PCR test. And, some people say, well, can we have carriers? Can we have people that don't know they have it, they just keep on carrying it? And the answer to that is yes, but it's a very rare thing. They had a study that came out last week that looked at a person who had a certain kind of cancer and was immunosuppressed. That person actually was positive, spreading the virus they were at 155 days. And so, but that person never was able to clear it. Their immune system just wasn't functional. And that is definitely atypical, but it's possible. One thing that people ask too is, can you get a second infection after you've had it once? And the answer to that is yes, but it's rare. And they have done these viral sequencing studies where they take the virus in a person who's infected and they can sequence the RNA in a machine, and then every RNA is a little different from SARS-CoV-2, from the virus. And so they can tell, for instance, if everybody in the family has the same virus or if somebody has another one. Now, they don't do that because it's expensive and it's not really that helpful. But they've identified 4 people so far in the world that have had a second different infection. So it can happen. They've looked for it many times and they've not, and most all the time, no, they can't.
So Dan, I'm going to stop right here a second and tell everybody, I know you all have questions. Somebody already sent me one via chat, and I don't know how to work chat, so don't do that. But if you've got a question, there's some way you'd be able to
Now,
raise
let's
your hand
stop
on your
here and see
screen.
who has one.
Pardon?
Let's stop here and see if anybody has a question.
Well, I want to tell them too that if you have a question as he's talking about something, wave your hand like that. And I'm going to ask, since there's so many people on, if John Henderson, will you help me watch for people waving their hand and let us know if somebody's looking, be my assistant. And if your question if we don't get to your question tonight, you can send it to me this week or just save it till next week and we will get on with that. But I know some questions that have already been asked. And one of those is, can you talk about, is the virus getting worse? Is it getting better? They say we've turned the corner, yet there are more cases. And yet if a vaccine is in the offing and could be here, like they announced on the news tonight, before Christmas available, wouldn't that mean we're kind of turning the corner and dealing with it? And also, as the coronavirus mutates, is it getting more severe or less severe, or is it just getting more contagious? These are the kind of questions that a lot of people have.
I think that the virus is very seasonal. So we pretty much expected from the beginning that, like all respiratory viruses, this would flare up in cold weather and calm down in warm weather. A lot of it's related to human behavior because, we get outside and we don't congregate close together as much in the summer. And also we know that the virus is transmitted by an aerosol. So that virus has to attach to a little bit of water droplet. And as the temperature goes up and the humidity goes down, that water droplet's going to disappear, evaporate quicker. And that virus is not going as far. And so as the humidity goes up and the temperature goes down, it'll go further. And they've done all kinds of studies looking at that, and it's proven that, and it transmits by aerosol. Yes, sir.
Chris, you got a question? Unmute if you got a question. I can't hear you, Chris. Unmute.
Okay, yeah. I have a question about from what I've heard, that the vaccines have a very critical temperature that has to be maintained in shipping and storage. And it's is that true for all the vaccines that we're looking at?
No, it's not. Right
But
now,
if we decide on one that requires that, aren't we going to have that in place long before the vaccines can be distributed?
well, hospitals currently have that. And so it's an ultra cold freezer that stores at 70 below zero. And 4 of the 5 in clinical trial, in the third level of the clinical trial testing, have to be stored there at that temperature. And that is a logistical problem that is basically going to be centered around hospitals. And the first 20 million or so doses that come out will actually go to healthcare personnel and nursing home patients. And then that's really going to be an issue with the next 100 million doses, they think. And it's going to be a huge issue around the world. But there are, right now, I think I read 153 vaccines for the virus that are in study. And many of those have storage temperatures that are much warmer. And so, I think that we're going to have to see which ones actually get approval for the emergency use authorization. But that is an issue.
But that would be limiting to hospitals. I mean, Walgreens is not going to do this, and country physicians are not going to have it. You're going to have 360 million people looking for a vaccine at a hospital. Is that correct?
Well, right now it looks that way, but I don't know what their plan is for that. But the initial ones, the first 20 million will go to the hospitals to be dispensed. And so we know that they can do that. I've been looking for the freezer. I found one that basically it's not very big, and it's about $8,000. So it's not crazy expensive, and I'm sure it'll be reimbursed through one of the government plans. But basically, they are available. So it's not an instrument that is prohibitively expensive. But I'm sure that's a problem that has to be managed.
And Dan, I've got a question here from Rosemary. It says, I have a friend who is getting paid to take COVID vaccine at a research place in Nashville. Do you recommend doing that if you're over 65 or any age?
If they're in a study, you have to realize half the people get placebo. Okay? Half the people get vaccine. And so part of the stage 3 study is to look at those people that get basically placebo and see how many of them get infected, and do the same with the ones with the vaccine. So I don't know the specifics of what she's doing, but it sounds like it's a study because there's no vaccine that's been given an emergency use authorization as of yet.
Rosemary, you want to say anything more on that? You have to unmute if you do.
No, I just wondered if I should go get the. It is a study at that clinical research, and she got $300 for doing it.
Yeah, it's a 50% chance she got the placebo.
Yeah, I know, but I'm scared I'd get the real deal.
And I probably wouldn't do it.
Okay, Ann Cooper, unmute. You got a question?
Well, following along with that, aren't they needing people, different races, different age groups, different, male, female, so they see how different people react to these studies for the vaccines?
Yes, that's true. And,
the suicidal tendency and you're over 65, you could go do it.
There you go. But I think that of the 5 that are in stage 3 trials, I think that 4 of those are fully enrolled. And so I think there's probably not a big need for people to volunteer at this point.
Have they released information? I mean, it sounded like they were going to try to make those studies in phase 3 more transparent, but I mean, has there been any news about how well it's going, or is that not going to come till the end?
Well, it's coming out pretty much every week a little bit. The the second stage of these studies looks at safety. The third looks at efficacy. And so right now, that's what these studies are doing, is looking at efficacy. And then what happens is, after they complete their efficacy evaluation, they take all their data and they submit it to the FDA and request the emergency use authorization. The FDA grants that based on all the documentation the company provides. Now, there is no company that will be licensed to have a vaccine for at least a year or two. Everybody will be operating on the emergency use authorization, and they're not going to release proprietary information until they get that authorization. So we won't know the total effectiveness. Now, they did pause 2 of the studies, the Johnson & Johnson study and the AstraZeneca study, because of side effects. Now, the AstraZeneca, which was the Oxford from England study, they had a patient who developed transverse myelitis. And we know that occurs in the general population. And they decided, based on everything they did, that they were convinced it was just a chance occurrence. I don't know how they do that. That's above my level of expertise. And then the J&J vaccine basically had a death. But then when they removed the code for the death, as far as the secret code, with the way they label it, the person actually was in the placebo group. So they may have actually died from COVID. But they did not get the vaccine. They died from the placebo group. So they resumed that study. And so
Okay,
right
John,
now, they're all running.
John Carpenter, you got your hand up.
A family had a gathering, and plus 80-year-old pair got the virus, and they were sent home. And they did well for a while, but is that something you can explain?
Let me ask for a little more clarity, John, on that. Tell me, did they get it from the group setting?
Apparently, I think one of the men had it and spread it.
Oh, okay. Yeah, one of the things they're showing now is a lot of the spread is actually in small groups. And, you know, they try to identify things such as time together and distance apart, and whether or not they're using mitigating instruments like a mask. And what they've come up with is they say that they recommend you not be with anybody over 15 minutes unless you're over 6 feet apart. Now, that's not very good instructions, really, because, you know, the time isn't where you can do 2 minutes and then start over. And I think that really what it is we all have to know that the virus is contagious. And anytime you mix households, you have an increased risk of transmission of the virus because you never know where people have been, you know, and then there are always people who get it, who say they haven't been anywhere. And right now, I think it's evaluating your relative tolerance for risk and deciding what are you willing to do.
But the couple that got it were 80 plus years old, and they were sent home.
Yeah. And I've seen several patients who have gotten it from graduation parties, weddings, and funerals. And so that's how you get it.
Okay.
And, you know, and
So you're saying, John, they were sent home from the hospital?
They were sent home from some kind of treatment.
Yeah.
okay, yeah. It doesn't surprise me, but, you know, I think that as we go along through this, we're learning more and more about the whole process, about how to test. Even testing has changed a lot in the last few months. And, you know, now we have antigen tests, we have PCR tests, and pretty soon there's a new type of test that is called CRISPR, CRISPR, that is even more accurate. And, you know, and so we're learning a lot. And I think that upsets people because as we learn more, what doctors say changes. And that's really disheartening because when you get a different story, you think, well, nobody really knows what's going on. And that's partly true. I mean, we're learning.
Thank you.
Catherine?
Faye's got a question.
Yeah.
I'd like to know about our grandchildren. Do children spread it really worse than adults to each other? Do we need to stay away from our grandchildren if we're above that 60 age limit?
Well, unfortunately, Faye, that's probably the best thing. Children can spread it. And we know that they don't get sick and they're fine, but you would, or you could.
Mhm.
And that risk is something that, is, and until we get a test that you can do every day, that is cheap, that you can do at home, probably that's the best thing. We're going to have the vaccine out soon, as one of them or many of them, however many, I don't know. But we'll have several vaccine candidates that are out. And I feel like that with the studies that have been done, they're certainly as safe as the flu vaccine. And if you are willing to take the risk of a flu vaccine, this is really not much riskier, if any, probably the same. And so, I will take it because I feel like I've got to sort of be an example I can't advise patients to take it if I don't take it. And so I think I pretty much have to do that. And, we'll see.
Will you take it as soon as it's available?
Yes.
John, did you have a question?
Yes. Dan, would you speak to the topic of herd immunity, which I've been reading a lot about lately? And could you explain what herd immunity is all about?
Yes. Basically, herd immunity is a term that comes from the 1930s from veterinary medicine. That is what it sounds like. It's if cattle were on one farm and the disease was spread through the state, what's the chance of it getting in your herd and spreading in the herd? And how it applies to the SARS-CoV-2 and COVID-19 is that there's this idea that if enough people develop immunity, that it stops the viral spread. Now, the two ways to develop, really there's three ways to develop immunity. One is you get the infection and you develop antibodies. The other is to be passively immunized with the polyclonal immunoglobulin, which is what President Trump had from the company called Regeneron, which that gives you antibodies passively. These are pure antibodies that are injected. Those probably last 6 or 8 weeks, maybe a little longer. What's really the most promising way to create herd immunity is through vaccination. Vaccination is a way that basically we can, really rapidly develop widespread immune response. And, the way we measure immunity is typically through an antibody test where you check to see if you respond by measuring your antibody level. But now we realize that with these viruses, a lot of people who develop immunity develop it through a second part of the immune system called the T cell memory pathway or the adaptive immune system. And that you can't measure with antibodies. So when you have basically a vaccine, you can have the vaccine and develop antibodies, or you can stimulate the T cells and develop protection that way. So basically the goal is stop the infection by not having susceptible hosts to get the infection. That's what herd immunity is.
So Dan, go ahead, Don. Don's got a question.
Dan, I'm sure you've had a lot of exposure with what type of work you're doing. Have you kept yourself safe with just the mask?
So far, so good, Don. I've had about 250 or 60 patients that have been positive that I've dealt with, that I've taken care of. And, I get tested about once a week, and I'm negative so far. But I'm careful. I mean, I wear my mask religiously. I wash my hands. I don't tempt anything.
So, I mean-
Dan, we've heard that the O positive blood type has a greater resistance to the virus. Have you heard anything along those lines?
I have read quite a bit about it, Jim. Basically, what it is the antigens for the O that are in the ABO blood typing protein group is very close to some very important immune function genes on chromosome 6. And it's probably not the O antigen that is significant. It's probably its relationship to other immune function antigens that are adjacent to it on the same chromosome.
So are there other factors that would make some people less likely to get the virus than others?
One of the things I was reading today that was really interesting, it was a study out of Spain that looked at people who were taking statins for cholesterol. And one of the things they found is that people who were already on a statin were 25% less likely to end up in ICU or die. And that, again, that's a retrospective study. That's not set up to look for that. They just tried to identify things that were higher risk.
Okay. Blessing of heart trouble. Yes, Catherine. Unmute, yeah.
Yeah, I'm just really curious about false negatives and false positives from testing. And I just wondered if you could speak to that.
Yes, that's a real problem. False positives definitely happen. False negatives are less likely, but anytime you have a test that is run by humans, that has human input, it's a setup for a screw up. And so it happens. But really, probably the answer to that is now, if you get tested and you're positive, and you're convinced that it's wrong, is to get retested the next day. That's probably the best thing. Now, pretty soon we're going to have these tests out that you can do at home.
How soon is soon?
I don't know. They're already made. They're just waiting on approval. And so, I had gotten a memo from Abbott Labs, who makes one of them. They're $5 each. And, that's in the range that people could have them at home. And, so I don't know what the delays are or anything like that. But I do know that I got a note that I might be able to have some available at the jail. And so if that's the case, they could just show up one day. But I've seen a picture of them and I've read about them, and they exist. I don't think they're like unicorns.
I've got two other questions that may seem to contradict each other, and we may not have time to answer them this week, but we can think about them until next week. Number one is in light of what you said about grandchildren and gatherings and so forth. What advice do you have for people with Thanksgiving coming up? On the other hand, part of the good news that I sense with the ongoing of this virus is that they discovered more things, like you mentioned earlier tonight, that they can treat people with who get the COVID virus. So doesn't that make it less threatening to most people if you get the virus, that there is something they can treat you with?
Yes, I think that's a great thing. But I think we have to remember that, all the evidence says the size of the inoculum, how much virus you get infected with when you get infected, has a big relationship to how sick you get. So the less virus you get inside of you, the less sick you're going to get from the virus. And I think that's where wearing a mask, doing the nasal lavage, it decreases the inoculum so that it's going to help you not get as sick. Unfortunately, for people who are at high risk, this is probably the last 3 or 4 months that we're going to have to really worry about this. And it's happening over the holidays, and that's terrible. But I think that, this will pass if we can just get through it and stay healthy and realize that, people at risk need to use extra precautions than people who aren't at risk. But there'll be a lot of infections.
I want to thank Dr. Rudd. Our hour, like I said, passes quickly, and next week we'll make sure he gets the right connection to get on. I've still got a dozen more questions that, to throw at you, and I want you all to think of some more for next week and either bring them to the meeting or you can send them on ahead of time, text them to me. But, we're going to talk, I want to talk about things like, you didn't mention washing hands. How about that? Is that still as important as ever? What about getting it off surfaces? What's the threat is that? Another question, and I don't want to get into it tonight, but is if there are 3 or 4 companies working on a vaccination and one of those comes out, how do you know which one's the best one to take? But you'll have to come back next week to hear Dr. Rudd respond to that one. But I want to thank Dan. Yeah.
Well, since you did bring up that thing about washing hands, maybe we could have a week of information about that. And not, I'd like to hear what Dr. Rudd has to say about washing hands and washing surfaces, because we've kind of been led to believe that that's not the way it spreads.
Well, let me just put this in before we end. There was big concern initially about what's called fomite transmission, which is surface transmission. And it's clear now that most transmission is basically aerosol. But, washing hands is important because that's what a lot of times we shake hands with people, we hug people, we kiss them, we touch our face, we touch our nose, our mouth, pick our teeth. It gets worse. And as we do that, we can transmit the virus. The amount goes back to the size of the inoculum. If we're dealing with somebody who is spreading active virus, they can have trillions of virus in their sputum, in their phlegm, in their nasal secretions. Every time they sneeze, it could be trillions that go out. And it's usually during the very early phase when they have no symptoms or very minimal symptoms. And that's what's tricky about it. But hand washing is very important. And, it's essential. And just like I think anything to decrease that intake of the virus particles. And the face masks are not the answer that solve everything, but they help to decrease the size of the inoculum. And when you're out where you're dealing with people who could be infected, or you could even be infected and be asymptomatic, then the face mask is helpful. And it also reminds us just to give everybody distance.
Is this a question for next week or a follow-up on this?
Well, this is it's a question for right now, if I can. How often should you change face masks, and does it help to wash them, or should you just throw them away and get a new one?
Throw it away, and I throw mine away every one a day. That's how I do it. I got a box of 1,000. And
you use these little blue ones like this?
I've got a cloth one that's a little thicker than that.
Okay.
That I basically got 1,000 of them in one box. And so, I just use one a day. And then I throw it away. Washing it is not a good idea.
Okay.
Okay, one more question for you to think about for next week. If you were the mayor of Nashville or the governor of Tennessee, what kind of guidelines would you put out there for people in terms of shutting down or not shutting down. But you got to come back next week to hear his answer to that. And with that, I want to thank you again, Dan. This has been great. The hour goes very fast when you get into this topic.